Good afternoon, everybody. I'm Anabel Fernandez from the Liver Vascular Biology Research Group in the DBABS in Hospital Clinic in Barcelona. Thank you for being today in the main session of the Young Investigator Liver Seminars. First of all, I would like to thank the organizers, Rafa Bañares and also Jordi Gracia, for having the opportunity to host the seminar of today that is entitled Nanotechnology for Cell-Specific Drug Delivery in the Liver. It's a great pleasure to introduce today's speaker, Dr. Nicholas Hahn from Sydney. And Dr. Nicholas Hahn is a lecturer based at the Concord Clinical School and also postdoctoral researcher within the Faculty of Medicine and Health at the University of Sydney. He works on the development of nanomedicines for the targeted delivery of therapeutic agents for metabolic disease. In summary, they chemically synthesize quantum dots and also nanoparticles, characterize their pharmacokinetic and dynamic properties, and engineer nanostructures that alter their applications within in vivo models of metabolic disease. With the results, his team has developed intellectual property around oral peptide administration. He is also part of Sydney SPARC program and co-chair of the Nanopharma cluster of the Sydney Nano Health Network, and also ACR ambassador for Sydney Nano, and secretary of the Faculty of Medicine and Health Committee. Due to his research, Nick has received several awards and in international conferences and also publications. He completed his Bachelor of Science and PhD at the University of Sydney in 2016. And the results of his PhD drew media attention both in Australia and also and abroad. Nicholas has worked within the Bosch and Colleague Institute in Sydney and also was a predoctoral fellow at the European Molecular Biology Laboratory in Heidelberg, Germany. Okay, Nick, thank you for accepting our invitation. And also thank you to be available at 11 p.m. in Sydney. And finally, I would like to remind all the audience that you can ask some questions in the chat that will be answered after the talk. Now you can start. Thank you, Nick.
Awesome. Thank you, Annabelle. That was an amazing introduction, and I'm very humbled to actually be here as part of this liver seminar series. I would also like to thank Jordi and Rafa for the invitation to talk to you today and to be a part of this seminar series. Hopefully my presentation does come up on the screen and you can all see my mouse since I probably will use this quite a bit. So just as a bit of a introduction to myself and particularly to our team, the last time I probably would have seen a lot of you would have been at the 20th International Symposium for Cells on the Hepatic Sinusoid in Sydney, Australia. And this might have been, I know for myself, this was the last international conference that I got to attend before COVID. So within our team, this is me here, and I am a postdoc under Victoria Cogger and David Lakuta within the biogerontology group at the Anzac Research Institute that's in Sydney, Australia. What our team particularly has a big advantage of is we use a quite multidisciplinary approach. So we have areas of basic science that particularly focus on liver and liver aging. Victoria has greatly contributed to over the last couple of years, ever since she finished her PhD. But we also have a broad clinical input from David. What we've now moved into to try and add more dimensions to our group is we've started working with both Sydney Nano within the nanotechnology perspective and Charles Perkins Centre that has a very centric focus on obesity and using a multidisciplinary approach to try and aim to address these areas. So we really do have a broad range of from bench to try and translate to the bedside. And what we're trying to do is use nanotechnology to make this transition. So a lot of what my talk is going to be about today is the liver, but also how we can utilize nanotechnology to target this particular area. And this gets into what I'd overall like what you'd be able to get out of this presentation. Given this is a liver seminar, I shouldn't have to terribly go into much detail about why we should focus on the liver. given that that's everyone's primary interest here today. But what I do want to highlight is the importance of focusing on the aging liver. But there's also areas of metabolism and diabetes that the liver is critical for, and that being able to use drug delivery to the liver for these conditions is an amazing area and opportunity to work in. The direct components of this talk will focus on the benefits of using nanotechnology for drug delivery. And I want to talk about our most recent work that uses targeting and controlled delivery to be able to target in vitro or in vivo single cell types, and how you can tune your nanotechnology to target those, but also then promote how a drug can be utilized and taken up into that cell. And then I want to look at the pharmacodynamic aspects of different drugs that you can deliver with nanotechnology, and also go through the toxicity profiles that we need to examine to make sure this technology is safe and can be then translated into humans. So I'll start off with the aging liver. And the liver, as everyone knows, is the metabolic hub of the body. And it's of critical importance to look after your liver because as we age, the liver does undergo a great deal of steps that promote different transcription and metabolic and epigenetic alterations. And this can occur in all the different cell types within the liver. In Kupffer cells, the liver sinusoidal endothelial cells, or the LSECs, hepatic stellate cells, or HSCs, and hepatocytes. Each of these cell types will undergo different hallmarks of aging, whether it's the transcriptome or the metabolic potential nutrient sensing pathways that might be affected. Kupffer cells will show levels of activation, interleukin-6 secretion, and adhesion to the endothelial cells. The LSEC will become dysfunctional with age, and you lose the ability of fenestrations, so the porous surface of these cells that allow passive diffusion of liposomes, insulin, and carbohydrates into the intracellular space in the liver. And you lose this function with age. What you do is you see accumulation of collagen and smooth muscle actin being released from HSCs, but you also see changes in hepatocytes. And what I plan to highlight with this is that each of these cell types undergo different phenotypical changes. And if we wanted to be able to target the liver for therapeutics, we need to be able to deliver specific drugs or specific molecules to individual cell types to try and promote the best physiological effect. And that's a lot of what we actually go on to work with. And this brings into why we should target the liver. And liver dysfunction leads to metabolic disease and poor drug clearance, which can then impede liver function. So not only is liver dysfunction leading to metabolic disease, but a lot of the therapeutics we do use for diabetes and metabolic syndromes target the liver and critically work here. And as the liver becomes more dysfunctional, these drugs can become less effective, and therefore you can't treat these types of diseases. And these are really important considering that diabetes and metabolic syndrome have the 5th highest mortality rate worldwide, and the inability of the liver to metabolize medications for these may contribute to how you can have a higher risk of cardiovascular disease, which is the highest mortality rate that you can have worldwide. So there's a very clear need for why you should need to target the liver, but also highlights that the liver is a complex organ that needs to be looked at from both a single cell point of view, but also from a whole system point of view to maintain optimal health for the liver. So what we have worked on, and what I'm going to discuss a lot in this presentation, is how you deliver 2 types of drugs for trying to be able to treat metabolic conditions within the aging liver. And what we have done previously in a review is look at different pathways that can be relative to the aging liver and how they're important for metabolism. So what we do know about with aging is that there is an incredible importance on using caloric restriction models to mimic and delayed aging response. So this will be in a mouse model that's had reduced food intake by 30 to 40%. These mice do tend to live longer. However, caloric restriction in humans is not an approach that we can broadly take to our populations. So what we want to do is find medications that can mimic this beneficial effect by promoting the same pathway that caloric restriction might be promoting in the liver, and then promote these pathways through these different types of drugs. So the two drugs I will be looking at initially is going to be metformin, which is an AMPK promoter, which has a broad range of beneficial effects that's promoted by a lot of different proteins and transcription factors. And the other drug I'm going to be talking about a lot is NMN, which acts to promote NAD, which in turn promotes STIRT1 and AMPK. So we're going to be targeting this particular pathway. So the first thing I want to point out for when we start talking about aging and pharmaceutical drugs, and when we want to start talking about therapeutics, is that aging induces a series of problems that can then have effects on how we're looking at different types of drugs and how we should do drug treatments. The first thing that's quite critically important is with age, we have a change in the effectiveness of how different drugs will interact within our body. And this doesn't just count for the liver, this is broad ranging within the body. The other aspect that aging does present is that we have a growing group of people that require medications that are then on multiple different medications. This is referred to as polypharmacy. And each of these drugs will interact with one another. Well, we also have elderly patients that have increasing series of comorbidities that can make medications quite difficult, not only to prescribe, but then you then have different effects on different organs that can then contribute to why drugs will be less effective. What I'm really trying to highlight is we have a definite need for precision delivery models that can control the release of a drug with minimal side effects and where the different organs are being targeted by drugs that then have effects that we don't ideally want. And nanotechnology can really provide this opportunity. So for nanotechnology in medicine, for anyone who hasn't experienced nanotech before, nanomedicine is a branch of medicine that applies the knowledge and tools of nanotechnology to the prevention and treatment of a disease. And you can see we currently have 3 areas that can be investigated. It can be used for diagnostics, it can be used for medical imaging, it can be used for drug delivery. It's currently been used in vaccines. Pfizer and AstraZeneca vaccines use forms of nanotechnology. It's really highlighted that nanotechnology can be used in this area and this space. And so nanotech is going to be having a lot of other different types of therapeutics that are coming out within the next decade. But it can also be used for regenerative medicine as well. What I particularly focus on is a particular type of nanotechnology called quantum dots. And these have the potential for both medical imaging and nanotherapeutic drug delivery. So nanotechnology can be used not only for imaging and drug delivery, but it can also be used as a biosensor, but also for diagnostic purposes as well. However, for the context of this talk, I'm mostly going to be talking about imaging and delivery platforms. So my favorite form of nanotechnology are quantum dots. So these are remarkable structures that are a part of nanoparticles. So a nanoparticle is a particle that is below 100 nanometers in diameter. And to just put that into clarification for size, if you were to look at your finger, that is 1 centimeter across. 1 nanometer is a millionth of that size. So you're talking about something that is infinitesimally small, an incredibly unique structure. And what happens when you start getting down to really nanometer sizes is you have quantum dots. So quantum dots are a subset of nanoparticles that are between 1 to 20 nanometers. The particles I'm going to be talking about in this presentation are silver sulfide quantum dots, and they're shown in this figure here. These particles initially start out between 4 and 5 nanometers in size, and you can see within this picture here, this grainy surface and line structure across. So this is silver atoms that are all lined up in a lattice, and the space in between is where the sulfide is stored. So this is taken on TEM imaging, and it's one of the only forms that can be used to individually visualize these quantum materials. So the reason why we like using quantum dots within a biological setting is if they are prepared in a certain way, they can have incredibly low toxicity. They can be designed that they can be water soluble and they can monodisperse potentially within plasma, but very readily within water. The other benefit of quantum dots is you can control their size, and they're very readily coated with different materials. But by and large, the most important reason about quantum dots, particularly related to the liver, is the liver loves eating nanoparticles and taking up nanoparticles. And ideally, the smaller, the better. Nanoparticles that are between the size of 5 to 8 nanometers will rapidly accumulate within the liver and the liver endothelium, and they'll be quickly scavenged and exocytosed. And this presents a really unique opportunity for both imaging within the liver, but also for transporting of materials and therapeutics. So I want to take you first through the life cycle of a quantum dot if we are going to give it via an oral means. So this is the data from an oral gavage in mice, where we have a quantum dot that's been radio labeled with a tritium marker. And we have 3 time frames that we're starting off with. The first is 30 minutes after it's been given orally, and then we're looking at its distribution in the blood, the liver, kidney, spleen, lung, the small bowel, and the fraction that we can't actually identify. And what you can see quite clearly is within 30 minutes of it being given by oral means, 60% of the radiation is accumulated in the liver, whilst 20% is still within the small intestine. And that's an incredibly fast accumulation within the liver. What is also really unique at this time point is very little accumulation is occurring in the blood. And once we achieve at a 2-hour time point, there isn't an increase in expression in the blood. So it's not achieving systemic circulation. It really is staying within the liver and the small bowel. So what we know about biliary clearance is that the liver can identify a material that it needs to scavenge and endocytose and take up, and can facilitate its clearance very rapidly back into the small intestine by the biliary system. And that's what we do actually observe here. We see that the liver rapidly has an accumulation of materials, and that the small intestine is the only other area that shows heavy level of expression. You do see minimal expression within the kidneys in this early time point. However, within the spleen and the lung and other organs, there's very little accumulation, suggesting that it's not systemically circulating. So what the benefits of an oral delivery system are, is that it seems to go within the small intestine, is absorbed from the small intestine, taken to the liver, but then it doesn't achieve passage past the liver. It's recirculated back to the small intestine. The other great advantage over a 24-hour cycle with quantum dots is that within 24 hours, 80% of the radiation has been excreted in the feces. And that's quite an impressive aspect, because if you can have a transporter that's being taken up very quickly into the liver, but then readily excreted, there's potential they could have much lower toxicity than other types of transporters. The other thing I really want to highlight for this sizing component is if we have tritium labeled nanoparticles that are made of silver and sulfide, but they're 100 nanometers in size compared to 5 nanometers in size with the quantum dots, is that within 30 minutes, they don't pass the small intestine. So it really is a size characteristic that's unique for about how they actually are taken up from the small intestine and transport to the liver. When we have done just single dosing toxicity, looking at AST and ASLT, we said that there's no change in these markers following a single dosage of quantum dots. And we see no changes in liver, histology, nor kidney, small bowel, or spleen, suggesting that this could be an area that really could be looked into. So usually the first question I get asked within this area is, how is it being cleared so quickly from the small intestine and achieving into the liver? So what we've done here is we have quantum dots that are bound to a 488 fluorescent label. We've given them a gavage in mice, then quickly excised out the small intestine, and then we're looking at live imaging of the small intestine. The space up here is the liver, and this is a blood vessel that we've visualized. So this is live imaging, so the image does jump around. However, you will see brief shoots of green in the blood vessel, and the particles within the lumen will slowly start transitioning as the video progresses. You start seeing shoots that go through down here. What we've also done is looked at the vessels that are leading out of the small intestine. So these are the superior mesenteric veins, And these are 15 minutes after a gavage. So this is material that's been cleared out of the small intestine. I should also point out that the resolution of these nanoparticles is well below what we can see with these particular microscopes. So all that does occur is just the green haze that can be seen within these vessels that slowly dissipates as we go from 15 to 20 minutes, suggesting it has been taken up, and it is quite rapidly being taken up from the small intestine. One of the best ways to visualize these materials within the liver is high voltage transmission electron microscopy. So if you want to be able to see an individual quantum dot, you can't do it with conventional microscopy. You are forced to use transmission electron microscopy. So what we have here is 2 hours after treatment. We've we've excised the liver, we've fixed it for TEM, and this is a non-stained tissue section. So you can see quantum dots within these images. What we see is within the luminal space, in this blown up image here, you can see two clear aspects. The first is that quantum dots are accumulating in what we call protein corona. So this is when protein from within the serum attaches to quantum dots, and they form these aggregate molecules. And these can be quite beneficial since these help facilitate transporting of quantum dots to the liver endothelial surface, as you can see it interacting here. When we look at within the LSEC itself, you can see that the quantum dots are individually dispersed within these LSECs. So they're not accumulating rapidly within these cells. Within lysosomes, they are freely dispersed within the cytoplasm. However, they're not accumulating within the nucleus, suggesting you can get cytoplasmic delivery that doesn't have accumulation within a particular area with just unlabeled quantum dots. The other thing you can begin to see with these images here is we have an LSEC that's then bounded by a hepatocyte, and you can clearly see one of these cells has a lot more quantum dots accumulating within them compared to the other, which is that hepatocyte. And this is the next aspect I want to go into of when we initially want to look at the distribution of nanomaterials within the liver. We can see, as we had before, there's very rapid accumulation of quantum dots that occur within the liver. However, if you just have a quantum dot that's by itself, it doesn't have any coatings on its surface, it doesn't have any changes in its functionality, you don't get specific targeting to individual cell types. What you see is that 20% of them will accumulate within the liver endothelium, 40% will occur in hepatocytes, and another 40% will occur within other cell types. So these will be your Kupffer cells, could be B cells, could be dendritics, could also be HSC cells as well. There's a very broad range that if you don't have functionalization of your nanomaterial, you're targeting the liver, but you're not targeting a specific cell type. So what we wanted to do was look at different functional biopolymers that we could place on the surface of these cells to see if they could help facilitate being taken up by one cell type in preference to the others. What we established is we used a formaldehyde-treated serum albumin molecule polymer on the outside of our quantum dots. This still had the same accumulation within the liver. Up to 85% was observed within the liver itself. And this critically is from an oral ingestion. And this is after 30 minutes. So 85% of something that's orally given is present within the liver within 30 minutes. And that's truly an amazing aspect with this polymer as well. What we do see with this particular polymer is it has a very high preference for accumulating within the liver endothelial cells, up to 70% of this fraction of the 85%. So about 62% is accumulating within one particular cell type from an orally ingested form of administration. What we've also looked at is other different polymers. We've looked at heparin as well as BSA. These didn't show any change relative to what the quantum dots were alone. However, with a gelatin-based biopolymer, we see that the accumulation in the LSECs goes down to 10%. Within other cells, was almost negative. but up to 80% could accumulate with hepatocytes. We've developed 2 biopolymers that can be used to tune to target the liver endothelium, and another one that can be used to target hepatocytes. And these are not terribly complicated biopolymers to produce, but they just need to be on the external surface of our material to help facilitate its particular endocytosis. So what I want to show here is a little bit more detail about the formaldehyde-treated serum albumin. So in this video, we have FSA that's got a 488 label on it, and then we've got an immortal L-seq cell line, which is SKF1. You can see the green dots on the external surface of the cell, and we can just watch just how rapidly the green dot will accumulate within the cell surface, accumulate on the intracellular surface of this cell. So these cells very readily scavenge up formaldehyde-treated serum albumin, and this could be an incredibly unique advantage by having it on the functional surface of our nanoparticles to facilitate its uptake. What we can also do in vivo, within an in vitro model, is also model that accumulation that we saw within the lumen. So that was the protein corona. So what we've done here is we've got our quantum dots, we've incorporated them with BSA to help them aggregate together, you can see in this area and here. And what we're going to see is how it engages with the cell membrane. You can do this with an in vivo model, in vitro model, in the SKF1 cell lines, the immortal L-seqs. You can see up here, the particles interact with the surface of the molecule with bits of it being taken off individually at different time points. And then they start to accumulate within the cell. You can see that also down here, where it's not the whole material that's taken up. Small pieces of it are taken up. BSA is taken away from the nanoparticles, and then the nanoparticles can accumulate within the cell. So this is a very nice model to see how it can, our nanoparticles can interact with different cell types to try and model how best to facilitate their uptake. This can then be expanded upon when we start looking at, well, if our nanoparticles are being taken up by these cells, how are they taken up? One of the unique aspects of using quantum dots is that they are readily taken up by a very non-specific means within these cells. So using radio-labeled quantum dots again, we looked at the effects of different inhibitors, or pharmacological inhibitors, for cellular uptake pathways. So we also looked at flippin, which is a calvorin-dependent inhibitor, amiloride, which looks at macropinocytosis, and sucrose, which is a non-specific inhibitor of both clathrin-dependent endocytosis and macropinocytosis. What we observed with quantum dots weren't functionally treated with any external markers or biopolymers, is that they can be inhibited from cellular uptake by any of these inhibitors, which suggests that quantum dots are taken up by clathrin, calvorin, macropinocytosis pathways, which is a really unique opportunity. Since it's taken up by so many different pathways, is there an opportunity to tune which cellular uptake pathway you'd like it to be taken up? So I'm just showing here is what our quantum dots that have the FSA, so formaldehyde-treated serum albumin. So this is the one that targeted the liver endothelium. That when you have this incorporated on the surface of our quantum dots, it can only get taken up by one particular pathway, which is facilitated by flippin, suggesting that this particular FSA molecule on the surface facilitates calvorin-dependent uptake. And it's quite unique to have that tunable aspect to our quantum dot uptake, since you want it to be able to control whether it's taken up into a lysosome or can be freely dispersed within cytoplasm. And that can be shown here. So what we're looking at is a still images from a time-lapse imaging platform. So we've got our quantum dots for a 488 label at 1 minute, 30 minutes, and 60 minutes. And we've stained these for lysosomes. So you can see between 1 minute and 60 minutes, there's an increase in the fluorescent intensity of lysosomal staining. And when you look at the overlay, you can see both the green and purple accumulate in these white groups here, showing that our quantum dots, if they don't have any functionalization, are taken up into lysosomes. And this then facilitates a great increase in the amount of lysosomes that are activated from these cells. So ideally what we want for certain models is something that's taken up into a lysosome, because then can be degraded, or you can have a particular quantum dot with a different functionality group that can inhibit lysosomes from forming and facilitate drug release within the cytosol. So you don't get that exposure to low pH and you don't get degradatory enzymes designed to break down our quantum materials for the drugs that you want to transport. So I've talked a lot about a lot of different advantages. So I'm going to now move on to some actual examples using some quite standard medications that are used within diabetes as well as metabolic disease. And the first one I want to talk about is metformin. So this is our AMPK promoter. So with metformin, it has a very unique aspect of being reasonably, it has a unique aspect that we can, it comes radio labeled from different companies that can be purchased. So what we've done here is we have the black lines that show 14C radio labeled metformin. And what we've done is attached that radio labeled metformin to a quantum dot. And then we have our tritiated quantum dots that are shown in gray. What you can see within the liver is where metformin is given via gavage, it takes over 8 hours to accumulate within the liver, with only 25% accumulating within the liver from the oral dosage. If it is attached to a quantum dot, it can accumulate within 2 hours in the liver, and up to 40% of it, of that oral dosage, can accumulate within the liver. And you can see, based on the similarity in the profile, that the quantum dot or metformin divulge after this 4-hour period, with the quantum dot slowly reducing up to 24 hours. However, metformin is still present within the liver for a longer period of time. What's facilitating this faster uptake is how quickly it's been taken up by the small intestine. You can see the black line, which is metformin by itself, has a very high concentration within 1 to 2 hours, with it slowly decreasing and reaching 50% after 8 hours. Whilst with our quantum dot formulation, 25% of it is present within the small intestine after an hour. And this is then maintained and then slowly decreases over time. You see a slight increase in blood accumulation with our quantum dot formulation compared to metformin alone. However, this is quite negligible in size and very little accumulation that's carried in the spleen. The main takeaway points from this are that if you attach a drug such as metformin to a quantum dot, you get faster delivery to the liver, you get more delivery to the liver, and you get a much quicker peak of action time. The next thing I want to talk about is how effective that drug can be if you just only attach it to a quantum dot. Metformin has a very unique property, is it's a insulin sensitivity, it promotes insulin sensitivity. So you do, with pre-treatment with metformin, get a blunting effect of an oral glucose tolerance test. So in mice, this is when you fast them for 4 hours, you give them a standard dose of glucose and you see how quickly they have a blood spike in their blood sugar, and then the time it takes for them to return back to baseline. And if you pre-treat these animals with metformin for up to 100 milligrams per kilogram, you can get a blunting of that effect. So they don't get the same spike in blood sugar because they have more faster and readily release of insulin, and you get a blunting of their overall area under the curve. Uniquely enough, when you have quantum dots that are bound, metformin that's bound to quantum dots, you get the same effect. So the drug is still inducing the same physiological effect. However, the key difference between them is the dosage that needs to be used. So the same effect that required 100 milligrams per kilogram of metformin can be achieved with 2.4 milligrams per kilogram. And you can see that down here in our PD data. The dosage of metformin that's required to induce the maximal effect is up to 25 to 100 times higher than the dosage required if you use a quantum dot formulation. When you look at this over different time points, you can see that metformin not only has a greater effect at the same dosage, but it also has a greater effect at a much faster time point compared to just the drug by itself. And that's a really important aspect to take away from this, is that quantum dots, quantum formulations of drug delivery can offer a really lower dosage of drug that's required. And based on the pharmacokinetic data that we've gone through, it doesn't have that systemic availability in the blood. It's got targeted release within the liver. So it's only acting in that site of action. So it reduces the incidence potentially of side effects that quite broadly occur with different medications. What I also want to show is it's not just unique to metformin. We wanted to look at other different drug types to validate this idea. NMN also induces reductions in blood glucose, but just not to the same extent that that metformin can also do. So there is still a blunting of the initial blood glucose spike, and then faster to return down to normal glycemic control at a faster rate. What this really does highlight with NMN, particularly NMN bound to a quantum dot, is that the maximal effect size can occur at up to 10 grams per kilogram with this drug. And this same effect can be induced with 0.1 milligrams. So that's up to 10,000 times less drug that needs to be used in order to induce the same physiological effect if you're using a quantum dot formulation and just attaching it to quantum materials. You can see when we start comparing the PK/PD data, it still has that same peak time to be able to induce, and it still has a greater effect size that's induced in the same dosage regime. So we've gone and looked at pharmacokinetics, so it's biodistribution. We've looked at pharmacodynamics within a single paradigm, so a physiological effect that we can measure externally. What we also want to validate is that our nanotechnology isn't interfering with how the drug would promote a pathway within a cell. So what we've done here is to look at saying that cascade pathway that these drugs are known to act on. So metformin very readily promotes phosphorylation of AMPK, and NMN promotes activation of STIRT1 and also accumulation of NAD within the liver. So what we've looked at here is whether metformin, which is shown in red, can promote phosphorylation of AMPK within the liver, hepatocytes, and the L-sex, and showing that that pathway is still promoted. And with our quantum dot NMN, we can still get activation within the liver of STIRT1, hepatocytes, and the liver endothelium. When we start looking at other lower down cascade molecules, such as cyclic GMP, our metformin in a head-to-head, our quantum dot metformin in a head-to-head to our just metformin drug alone promotes an increased expression of cyclic GMP within the liver and within hepatocytes. But interestingly enough, because we have more accumulation within the liver endothelium, we have upregulation in these cells with our quantum dot formulation, but we don't see this effect with metformin treatment alone. So we're getting that added benefit of having metformin being delivered to the liver endothelium, and this may contribute to why we're seeing a greater physiological effect in our oral glucose tolerance data that we just presented before. And this effect is also observed with our quantum dot NMN versus our NMN treatment. We see that both these treatments greatly increase the amount of NAD within the liver and hepatocytes, but interestingly enough, within the liver endothelium, only the quantum dot NMN formulation promotes an increase in expression, whilst NMN alone doesn't promote this effect. So this added benefit could then be correlated with what physiological benefits you can then start seeing. One of the other key things that we pointed out before with the in vitro data is we had that ability to choose how it's taken up into a cell. So with our quantum dot metformin versus just metformin alone, when we isolate out some hepatocytes and then look at whether we can inhibit treatment or not, we identify a very interesting aspect. So metformin in both the small intestine and when in the liver is critically dependent on one particular transporter. And this is the OCT1 transporter. And this particular transporter can not only be blocked by protein pump inhibitors that are very readily provided to patients, particularly diabetics, but there's also a subset of diabetics that have a dysfunction of this receptor. So if we can bypass this transporter, if we can bypass the need for this transporter to take up metformin, we can effectively provide a way to deliver metformin without this particular transporter. So what we've done here is we've done in vitro endocytosis in hepatocytes. So these are cells that are given radio-labeled metformin or radio-labeled metformin attached to our quantum dots. And we've pre-treated them with a protein pump inhibitor, which is osmopriol. And we can see with metformin alone, there's an inhibition of how much metformin is taken up by these cells with the pre-treatment. When we look at with our quantum dot formulation of metformin, not only is there a greater uptake in our controls between just by attaching to quantum dots, we also see that pre-treatment with our protein pump inhibitor has no effect on the amount of metformin that's taken up into the cell. However, if you were to block both clathrin and macropinocytosis endocytosis pathways, you then get an inhibition of metformin being taken up. And this is quite unique because we've shown that we can mitigate the need for this OCC1 transporter. So we have a formulation of metformin that's not dependent on the original pharmacological required receptor. And that's a really critical part about what nanotechnology not only offers to our work, but can offer more broad-ranging reach to a lot of other people's work. What we also want to do was to validate this principle with NMN. So NMN requires a different method for its uptake into a cell. It needs to be dephosphorylated prior to cell entry, where it's then taken up in this dephosphorylated version, and then requires to be rephosphorylated and then used to produce NAD. So this can be blocked with cysteine monophosphase, as we can show here. So the amount of NAD produced when an NMN treatment is given is greatly increased compared to a control. This can be inhibited with the cysteine monophosphate pretreatment. However, if we attach it to a NMN to a quantum dot, this pretreatment doesn't inhibit the accumulation of NAD within these cells. However, as we showed in the previous experiment, if we use the non-specific inhibitor of this nanoparticle uptake, we can inhibit that NAD uptake. So we are getting to then choose how it can be taken up into a cell and mitigate potential problems that might be related to why a particular drug isn't as active or as useful in people, particularly in disease, if they have inhibitions of different channels that are required with changes in the molecules. It doesn't require those initial modifications to occur. You can just deliver the drug in full into the cytosol of your cell of choice. So the last area for NMN I want to talk about is to see the effects within an in vivo model of aging. So what we've done here is we've got 2 weeks treatment in drinking water with our quantum dot NMN and NMN. And these are in 2-year-old mice, so 24-old mice. What we can see is with our quantum dot treatment compared to NMN, there is a tripling of the amount of NAD that's produced compared to NMN, which has just produced a doubling. I also should point out that the quantum dot NMN uses a 1 in 100 the dosage that's required with NMN. And the other key aspect is with our NMN treated, we see no change in their oral glucose tolerance, no change in their fasting fed insulin, and no change in their insulin resistance scores. However, with our quantum dot NMN formulation, we see reductions in their oral glucose tolerance test, fasting insulin, as well as reduction in their insulin resistance scores. So we've made a drug that becomes less effective as we get older, more effective by changing its and increasing its biodistribution and its cellular accumulation by using nanotechnology. So the last drug that I do want to touch on just in the last few minutes is what other things can we deliver? Can we deliver medications that can't normally be given orally? And what we've begun focusing on is looking at, can we deliver insulin with this nanotechnology? So insulin, as many of you would know, can inhibit the oral glucose tolerance test since it promotes faster uptake of glucose. And we can see with a subcutaneous injection of insulin that's given 15 minutes prior to the oral glucose tolerance test, there's a blunting of this curve. And with our oral formulation, we have the same time frame of action. So we can get that blunting again, that's shown in the area under the curve here. So with this model, the injection we're using is 2 units per kilo. The dosage we require for our oral formulation is 20 units per kilo. And you can see here in the pharmacodynamic effect here. The other interesting component is with increasing dosages of subcutaneously injected insulin, you will push these mice further towards hypoglycemia. However, by just targeting the liver individually with our oral insulin technology, without targeting other areas of insulin axon, you do get a blunting of this effect. So you can reduce the blood sugar of these mice down to 5, but you can't push them down into 2 or 3, which is hypoglycemia. The last aspect for this is to look at a type 1 diabetic animal model. So this is insulin tolerance test, head-to-head comparison between subcutaneously injected and oral insulin. Both are given at time 0 and both can induce the same reduction in blood sugar in the same time frame of action. So within 15 minutes, you can get 50% decrease in blood sugar with a dosage that was 25 times higher than what was used for subcutaneous insulin. Finally, I do want to highlight just the safety and toxicity profile of these nanoparticles. What we've done here is we've used silver sulfide quantum dots, 100 days everyday treatments with a dosage that's 10,000 times higher than what I just showed for the oral insulin data. And what we did was we looked at whether there were changes in body weight, AST, ALT, as well as plasma markers for interleukin-6, the recruitment of immune cells, MIM2, which is the homologue of interleukin-8, which shows recruitment of non-active immune cells, as well as interferon gamma. All of these showed no significant changes. We looked within the liver histology. We looked at MEPTA scoring, showed no more increase in fibrosis, even with 100 days treatment. And then we also looked within the kidney and observed that creatinine levels were not drastically increased. And we saw that there was no thickening of the glomerular membrane. Overall, this profile that we examined suggests that there was no toxicity, even when we're giving such a very high dosage that was never going to be therapeutically relevant, to show that these particles can be incredibly safe. So in conclusion for this talk, I'd like to thank everyone for listening, and hopefully I've been able to highlight the benefits of nanotechnology for drug delivery, particularly to the liver. Nanotechnology offers a really unique aspect that up to 80 to 90% of the nanomaterial will accumulate in the liver, and it is a fantastic transporting material both for drugs but also for other types of therapeutics for proteins and peptides. There's tunable aspects of cellular uptake and how a drug can be utilized, and if anyone has any questions about that, feel free to ask about how it can be relevant more to your particular project. Nanotechnology has a fantastic ability to increase pharmacodynamic activities, and it can be a non-toxic platform when prepared in certain aspects. What this also should highlight for everyone, but I highly doubt it really needs to be pointed out within the liver seminar, but the liver is incredibly important. It is the metabolic whole of the body, and all diabetes medications act on the liver, and all can be improved by targeting the liver with greater efficiency, particularly within diseased models. What we've shown here is you can use medications such as metformin and NMN to target aging of the liver as well. So it's a double benefit given these medications can also be used in diabetes. Just as a last thank you, I'd like to show my appreciation particularly to Victoria and David and all the hard work and mentoring they've provided to me over the last couple of years. It has been amazing so far. I'm really excited for the future. Glenn, who probably does more of this work than I do, and has been a fantastic help for me. I also want to thank people from pharmacy, Sophie Kang, as well as Peter McCaw from Tromso, Zdenka from physics, some previous other students, and as well as our funding bodies, NHMRC and Australian Diabetes Society. And I'm happy to have any questions, and I hope you all enjoyed the seminar.
Thank you very much, Nick, for this amazing talk with all of these promising results. And before continuing, let me introduce and welcome to your mentor, Dr. Victoria Kocher. Thank you for being here in this discussion part with us. And also to my mentor, Dr. Jordi Gracia. Thank you too.
It's a good question. So what? So for I could probably comment on two things. First being LSEX and others being hepatocytes. Hepatocytes are more sensitive if you do starve them to promote greater uptake. With liver endothelial cells, however, whether they're starved or not, there's no change in their uptake. So what I have done is taken away their sugar for up to 4 hours, and they still have the same uptake as if they were fed that entire time. You can get faster uptake. So I think we did a 30-minute point and a 2-hour time point. You do get more accumulation more quickly, but over a 2-hour period, there's the same amount of uptake. And I think that's in preliminary, in our supplementary data in the ACS Nano 2020 paper from memory. If not, you heard it here first.
Okay, thank you.
Yes, it takes a tiny bit of organic chemistry skill, but if I can master it, anybody can. What the easiest attachment strategy, and we published this in both ACS Nano papers, is to use C-terminus to N-terminus binding. So that's a carboxylic acid group to a primary amine. It's the most readily bond to form. It only takes 4 hours. You mix 3 different ingredients and you leave it to mix. It's not terribly complicated. So if you've got a quantum dot that's got carboxylic acid groups on its outside surface, if you've got a drug that has a primary amine, very readily and easy to do. That being said, if you don't have those two bonds, there are other alternatives to go with. Sulfide to sulfide bonding, quite readily and easily able to do. Hydroxides can be converted to a carboxylic acid groups. Phenyl groups can also be used for their attachment. There's just an increasing amount of steps that need to be done, but you can usually readily attach most water-soluble related drugs to quantum dots. With that being said, you can use lipophilic type of drugs with different surface modifications on a nanoparticle to facilitate their uptake. So if you've got a quantum dot, it's then got a lipid layer on the outside, you can then use that to attach a lipid-related drug. And then you can either have that being in a hydrophobic environment or a hydrophilic environment. It's just different levels of complexity. So it depends what you want to attach is probably the best way to put it. But all are able to be done. So what we've done is to look at, it is cellular dependent on how long they're kept. So with quantum dots that aren't functionally modified or are used for delivery of metformin, within 24 hours, they are completely, 85% of them are all excreted from the body. Within 72 hours, 95% of them are excreted. So it's a very short time frame of window that you're looking at. And what was the second half of that question? So what we've done so far is to look at 2-year-old mice. So they are heavily capillarized by that point. And we've looked at 16 and 20-week high-fat diet. So we haven't looked at full cirrhosis of the liver. I'm assuming with changes in both its vascular dynamic functions. So vascular dynamics does affect mathematically how a quantum dot or a nanoparticle interact within the liver, and that's been modeled and looked at in a couple of papers already. So you need to have quite substantial changes in vascular dynamics to really start impacting about how much can be taken up. So you lose that slowing down that you get within the liver. Within vascularization, that will affect how much nanoparticles are taken up. With that being said, however, nanoparticles that will attach to the surface of the cell will then affix at that point. They really, what better vascularization does is just increase the likelihood that they're going to collide with the side of the wall. They're still going to affix because they're designed to attach and be eaten by those particular cell types. So it doesn't require like affinity mediated binding for their attachment. If you want it to be eaten by a particular cell type, you can facilitate that. But just how bad a liver has to be, I'm unsure. It would be dependent on probably a lot more investigation. I can say I have seen some really bad livers in our 2-year-old mice, and they still have the same amount of drug accumulation as a healthy liver. We've seen cancer that's completely riddled an entire liver so far, and it still had the same amount of quantum dots present within them. So there's kind of a trade-off. You've got a really bad, unhealthy liver, but then you've got extra increased permeability within it, and that helps nanoparticles get through anyway. How well that targeting is, you're not quite sure, but it's something that can we'll be looking at in the next couple of years, and I'm excited to learn and figure out. So metformin has a primary amine group. So we use carboxylic acid groups on the outside surface of quantum dots. So we start off with a silver sulfide quantum dot that's got a sulfide molecule on the outside surface. We then convert that to carboxylic acid groups on its surface. So this has all been published. It's in ACS Nano 2020. I think you probably just look me up. I don't have that many papers. And it's the ACS Nano 2020 paper and 2021. So we have 2 of them that both use that metformin conjugation. It's very simple and straightforward. It's a 2-step process that takes a couple of hours to attach. Metformin can be slightly problematic, however. It doesn't like changes in pH that are required for chemical attachment. So we just limited the amount of pH change that was required, but that's only the tip you need to have in order to do it. So I don't have any published work on this, but it is something we have looked at and do plan to look at with a few different medications. Cancer cell direction, the best answer for this is to look at what is expressed on the external surface of particular cancers and cell types within the liver, and then use functional groups on the outside surface. So instead of using an FSA, using something else that will bind to a receptor that's on these particular cells. So with cancer cells, there will be greater vascularization, they will have greater uptake just due to their permeability, but having an affinity antibody that can help facilitate that uptake can be highly advantageous. And then you can use that to, of course, deliver an anti-cancer drug. The risk you always run from that is because there might be accumulation in other cell types, there's a risk that there might be toxicity associated with that drug. So you really want to start thinking about not just one particular antibody for affinity to try and facilitate uptake, but try and have 1 or 2 or 3 that are going to then try and better target those cell types. Yes, so if you use, we've taken this on a different type of approach of if you have diseases within the gut, would it be potential then to deliver therapeutics to those cell types as well? So the answer is yes, you can use this type of technology for that delivery, and a lot of our groups have started looking at that. The effects of different diseases and having that particular model, we haven't looked at that yet. What we have done is look at where the uptake is being facilitated. So it occurs very early in the small intestine and the duodenum, and it does occur more readily by certain endocytosis pathways. So we looked at, again, with like clathrym, we looked at calvarium, we looked at metapropienocytosis pathways. There's the same 3 pathways that seem to facilitate uptake of these nanoparticles. So we really are not dependent on a particular channel for this uptake that's affected by a particular disease within the gut. It does seem to occur across multiple different channels. We kind of have more options for its uptake, even within a diseased gut. But we still need to look at that in a lot more detail to know for sure. A nice simple approach for it. So the sealing effect is when you're going to start getting toxicity to the organ in the liver. So we figured out where that barrier is. It's about 7,500 micrograms per kilogram. That being said, though, it's the other sealing aspect would be the amount of drug that you can load onto a nanoparticle for its delivery. What we have seen within certain cell cultures is there isn't a sealing effect for quantum dots, but there's a sealing effect for what the drug can do for the particular cell. So what we've seen is if you've got 1,000 times more drug than the cell's ever going to need, that drug is going to be toxic to the cells faster than the nanoparticles were. So the drug will be the sealing effect, and there's not so much of just overloading it with quantum dots. That being said, if you do overload it with quantum dots, they will become toxic within those cell types. But it's more drug toxicity that we've run into, and we've started looking at therapeutics as opposed to quantum dot toxicity.
Thank you, Nick and Victoria.
Thank you.
For being here today, sharing your expertise, and also thank you to the audience one more time. See you.
Thanks a lot. Bye-bye.
Thank you, Jordi, too.
Bye-bye. Thank you.